Good morning from the annual meeting in San Diego. We're pleased to be here with Dr. Terry Kim. Thanks a lot, Terry, for being with us this morning.
Thanks for having me.
Terry, one of the great presentations at this meeting has been about corneal pathology and how it impacts our IOL calculations in cataract surgery.
Yeah.
We know that corneal pathologies present frequently in combination with patients who need cataract surgery. So tell us a little bit about how you approach this kind of scenario. What kind of cornea problems typically present, and how do we go about evaluating and treating these patients?
Well, we all know we want to optimize the cornea prior to cataract surgery because it's going to help us with our IOL calculations as well as their visual outcomes. I mean, Alice Apatropoulos did a great study looking at using hyperosmolality as a tool that can affect our IOL calculations. So not only the dry eye, but other conditions can affect the cornea. Very commonly, anterior basement membrane dystrophy and Salzmann's nodular degeneration. And these are conditions that we see in our patients fairly regularly, but we don't think about the impact that can have on their cataract surgery. So Mark Jensen is one of our residents. Priya Gupta, my partner, we decided to look at this in terms of the patients that we had treated for this condition and specifically the impact it had on IOL calculations. And the criteria we used is if these patients have these lesions in the central 3 to 4 millimeters of the cornea, if they have inconsistent keratometry or biometry measurements that's shown usually on their LensStar or IOL Master, if topography identified irregular astigmatism and or dropout, or if these patients were symptomatic, those were the criteria that we use to treat either ABMD or Salzmann's nodular degeneration with a superficial keratectomy and possible PTK as well. And it was really surprising what the results showed. So it was a retrospective study, but we found that it was statistically significant in both patient populations that the mean keratometry and the IOL power closest to plano were different when we did that biometry prior to the intervention and then a month after the intervention. And roughly more than 80% of these patients had a change in their spherical IOL power as well as the IOL power toricity. So the change in toric IOL power changed in a very high percentage of these patients. So very clinically relevant.
That's a really great point, Terry, and I want to ask a little bit about the logistics of how you would approach this. Let's say that somebody has bilateral disease, such as bilateral epithelial basement membrane dystrophy. Would you perform the superficial keratectomy in the same session in both eyes, or do you do it in a delayed sequential format? And as a follow-up to that, you mentioned 4 weeks is about how long you would wait to remeasure the biometry.
Right.
Do you find it necessary to measure again 6 weeks or 8 weeks out? Does it take longer to stabilize in some patients?
Yeah, so yes, it does. Let me answer that question first. We certainly do evaluate them about a month after, do a repeat keratometry and biometry, and then we also certainly assess their ocular surface with a slit lamp exam and vital stain dyeing to make sure that that surface looks regular. If not, there's a very low threshold for bringing them back in another month to get repeat measurements, and we want to see consistency there. Can you remind me of the earlier question?
Sure. The first question was about treating the superficial keratectomy procedure in a bilateral format or in a delayed sequential format.
And it depends somewhat on the patient. Some patients don't do well with these procedures, maybe have difficulty lying down in those scenarios or travel for far distances. Those scenarios we may do a bilateral treatment, but the majority of our patients are treated sequentially. So I'll do the SK/PTK in one eye, and usually the bandaged contact lens comes out in about a week. So the following week, if everything healing looks good, I'll go ahead and do the second eye and then wait about a month after that second eye to repeat the biometry measurements. And patients tolerate that very well. As long as you inform them that they have a condition that can not only affect their measurements but their visual outcomes after cataract surgery, patients understand. Because if you don't do this beforehand, they're going to look at the toward optical the result as a complication. So set their expectations up front so they can actually blame the disease process and not you.
That's a really great point, and I'm glad that you spoke on how to properly counsel your patients so that they're on board with the treatment process, because patients may may encounter this as an unexpected step in their treatment for cataract. Why do I need to go through this extra step? It seems like a proper explanation and a proper counseling can really go a long way there.
Very important.
I want to close by asking you about premium lens implants, specifically about toric implants and about presbyopia correcting implants. If someone has, let's say, Salzmann's nodular degeneration or anterior basement membrane dystrophy that you have treated successfully with a superficial keratectomy, could they be candidates for these types of premium lenses?
I think that's an excellent point. I mean, certainly this is relevant to our whole cataract surgery population with the monofocal IOL, etc. But particularly for the premium lenses, you want to make sure that your measurements are accurate so that you have a good outcome. Because certainly the expectations are higher when the patients are paying an out-of-pocket fee. So our study, which is going to be published in JCRS, clearly showed that treating these lesions can have a tremendous impact on IOL calculations, specifically also on toric IOL ptericity, right? So, yes, if you treat these patients and get good measurements afterwards, I think they're great candidates for these premium lenses as long as they don't have any other reasons to defer, whether it's maculopathy or optic neuropathy. So if their surface normalizes and you get good measurements, I don't see why they can't be a good candidate for this.
Well, Terry, this has been a terrific discussion for us this morning about the importance of normalizing the corneal surface prior to embarking on cataract surgery. Thank you so much for sharing your expertise, and thank you to our live audience for your support.
Thanks for having me.
Mm-hmm.